Good afternoon, everyone. A very warm welcome to our esteemed speakers, moderator, and participants joining us today. I am Dr. Vaishnavi from the team of Voice of Healthcare, and it's my privilege to welcome you all to this important leadership discussion titled Beat TB: Early Detection and Better Protection. This session is an initiative by Voice of Healthcare supported by Cepheid and is being hosted on the occasion of World TB Day, a day that serves as a global reminder of the urgent need to eliminate tuberculosis and strengthen our public health response. Tuberculosis continues to remain one of India's most pressing public health challenges, with the country bearing the highest burden of TB globally. While significant progress has been made under national programs, several critical challenges still persist. Delays in early diagnosis, underutilization of advanced diagnostic technology, limited access to quality laboratory infrastructure in certain regions, and fragmented care pathways that often lead to missed or late detection. Today's discussion aims to address exactly these gaps. Through this leadership panel, we seek to explore the current realities of TB diagnostics in India, identify systemic and clinical barriers, and discuss actionable strategies to strengthen diagnostic pathways, improve collaboration between clinicians and laboratories, and leverage innovation to accelerate early detection and ultimately move closer to TB elimination. We are truly honored to have with us an esteemed panel of experts: Dr. Pratik Savaj, Director and Infectious Disease Specialist, IDCC Hospital. Welcome to the session, Dr. Pratik. Dr. Mary Diaz, Professor Microbiology, St. John's Medical College. Welcome to the session, Dr. Mary.
Thank you, Vaishnavi.
Dr. Reena Raveendran, Institute of Clinical Microbiology and Immunology, Sir Gangaram Hospital. Sorry, Senior Consultant, Institute of Clinical Microbiology and Immunology, Sir Gangaram Hospital, New Delhi. Welcome to the session, Dr. Reena.
Thank you, Vaishnavi.
Dr. Mallika Ghosh, Zonal Head, Dr. Lal PathLabs, Kolkata. Welcome to the session, Dr. Mallika. And guiding this insightful discussion, we
Thanks,
have
Dr. Vaishnavi.
thanks. And guiding this insightful discussion, we have our moderator, Dr. Swati Tripathi, Director, Clinical Solutions, Cepheid. Welcome to the session, Dr. Swati.
Thank you so much, Dr. Vaishnavi, and we are looking forward to the session.
Sure. So we are confident that this panel will bring forward diverse and valuable perspective across clinical practice, microbiology, diagnostics, and public health policy. With that, I would now like to hand over to the session to our esteemed moderator, Dr. Swati Tripathi, to take the discussion forward. Thank you, and over to you, Dr. Tripathi.
Thank you so much. Thanks, Vaishnavi. And without further delay, let's just start and dive right into it. I welcome Dr. Pratik, Dr. Mary, Dr. Reena, and Dr. Mallika to this, and we all are looking forward to your insights. Now, Dr. Pratik, Let me start with you. And first, actually, let me say this: we all follow you on LinkedIn, and see your wonderful posts about multiple subjects actually, and the humorous way that you put it is very appealing. So, with that, let's come to the serious question. So, you have a frontline perspective on infectious diseases. Want to ask you, what are the most common clinical and systemic barriers that you see which lead to diagnostic delay for TB? And is there any particular patient population or any particular clinical presentation that you see where tuberculosis is frequently missed, or sometimes is diagnosed late? So over to you, Dr. Pratik.
Yeah, thank you so much, Voice of the Healthcare, for inviting me as a speaker. And thank you, Dr. Swati, for raising very important question. That see, we need to accept that TB is one of the common infectious disease in our country, and it is one of the frequently missed infectious disease in our country. So the common barrier I would like to divide in two part: one at the patient level, and second at the healthcare level. So at the patient level, there is very low symptom awareness in the community. For example, if any patient has a cough, so his first response would be he will directly go to medical store and buy cough suppressant. Second, I have seen that many patients they follow non-allopathy route for respiratory tract infection and whatever thing. So they again take some cough suppressant and they like to suppress their symptom. So there is very low community level awareness regarding the symptom of tuberculosis. So I just would like to tell the clinician that if any patient has a fever and cough more than 2 weeks, first thing we need to rule out tuberculosis in India. So second, the problem is also at the level of stigma. Patient like to avoid, saying that there is a possibility of tuberculosis. So many patients don't like the stigma of tuberculosis. The I would say that more problem is at healthcare level also. So there is very nice study done by Dr. 𝗕𝗿𝗆 regarding the what is the first response of a general practitioner when the classic symptom of tuberculosis is there. So he has conducted very nice study, and in that study, the patient goes to clinician with the classic symptom of tuberculosis, like fever of more than 2 weeks, cough more than 2 weeks, and weight loss. So the result was surprising. The result was the common response from the clinician was to give antibiotics. So commonly antibiotics were given as a part of treatment rather than the investigating why there is a patient is having cough. So I would say that basic chest X-ray or sending sputum for CBNet would be enough as a part of workup of any patient with cough and the fever and weight loss. Uh, Still, many clinicians rely on traditional AFB smear examination. I would say that, see, doing traditional AFB smear examination is not a problem. But when the disease is like possibacillary, we need to do, sputum for CBNet. So, only relying on chest X-rays and doing sputum examination is a problem. Then you raised a very nice question that in which group we can miss tuberculosis. So a patient, those patients who have low immunity, like HIV positive population, or patient is receiving chemotherapy, or patient has a extrapulmonary tuberculosis like back pain, headache. So these are the patient we feel that mostly there is a high chance that we might miss the diagnosis. And let me tell you, I have not published this thing, but in my clinic, the average time of any patient reaches to my clinic is roughly 3 months after the symptom onset. So this is how the poor referral system is also there in healthcare, which might lead to delay in the diagnosis of tuberculosis.
No, this is very, very well elucidated, Dr. Pratik. And I mean, if I could, some points that I was noting down, wherein patient has, sometimes there is a stigma, sometimes the awareness of the patient itself, because yes, I mean, we all feel that cold and cough and fever, it's like a small thing only, and TB is far ahead in our imagination perhaps. And a very interesting study you mentioned, the study by Dr. Pai, wherein the clinicians themselves were missing the early symptoms. And if you are doing a point of doing AFB or the smear in early stages when it is possibacillary is of no use. So a
Yes.
very good point made there also, that a NAT would be probably a better choice of diagnosis. So with this, let me come to you, Dr. Mary, because you have the crucial role in confirming TB diagnosis. Wanted to ask you if you can put some insights on what all are the key microbiological and lab challenges that you currently face, which are affecting the timely and accurate diagnosis for TB. And it could be across different healthcare settings in India. It could be in a hospital in pure play lab setting. It could be in PHC or a referral center. What do you think are the challenges that a laboratory faces?
Thank you, Dr. Swati. Very pertinent question when we are dealing with the challenge of ending or eliminating TB as the country's vision goes. So, from a laboratory perspective, if you see, the challenge is not the absence of diagnostic, and like Dr. Said just before me, the clinician's thought process itself that TB is there is a very important part even before we even start the laboratory diagnostic. So that is called a pre-test probability. So when we get the idea of a patient coming and how much do you think there is TB is a very important thing before they actually send a sample to us. So once the sample is even coming in, it is not that we don't have good diagnostic tools. So what is available, when is it available, and whatever is available, is it quality assured, is a very important thing that we have to ask in a laboratory perspective. So what we are looking for is an equitable and a quality assured test that we look for. And we know that the scale of TB is so high in India, and we contribute about 25 to 27% of the global TB burden itself. There is so much of heterogeneity in our healthcare settings, right from PHCs till tertiary care hospitals. Now, if you look at the vision for the country for elimination, so much of accessibility has happened. NAT is available even at peripheral healthcare settings. Now, why is it still are we missing? Is because probably in a peripheral healthcare setting, although it's a free test, probably there is an overburden of samples. So we are not able to give a timely report, although a NAT facility is available. At a tertiary care setting like mine, although we want to do the test and NAT is available, it is still patient driven, meaning patient has to pay out of his pocket. So that may not be the first test which he is going to use at a tertiary setting. So at both places where it is free, it is overwhelmed, and at where it is, they are able to pay and get a test done, it is still unaffordable for many people. So these two things have to be very, very thought about and kept in mind when we are driving towards some particular way of testing, although it is a very good testing ways. Then next what we say is diagnostic, there are a lot of gaps in the pathway itself. So many places where we use these tests like NAT and other things, or even microscopy for that matter, we should be very careful. Is this quality assured? Now, is my lab capable? The doctor should be, confident enough to say that whatever comes from my lab is quality assured, and I know it is truly negative or truly positive, and I do not have any doubt about this thing. It's a very, very important step in a laboratory. And why it doesn't happen always is that quality assurance is expensive. The tests that we have to do to keep the machine up in calibration as well as quality assurance is quite expensive. So it is not affordable maybe at peripheral health centers, and at a tertiary healthcare center, this will be transferred to the patient. So both ways it becomes very, very expensive. And last is, we always look at turnaround times and integration issues. So even if I do a test, How far am I able to relate to the clinician quickly? How far is the clinician able to start the treatment immediately? This is also a huge diagnostic gap. I may give a result, put it on the system, and sit back thinking that automatically the patient is going to get treated. And doctor said very clearly that when the time they see the patient to actual treatment starting is 3 months, there is such a huge delay in the time that they actually see a patient to doing the treatment which is appropriate. So that is a big, huge diagnostic gap, if you ask me, more than starting of treatment and this thing. So therefore, these are all the challenges I would say that, that although good technology is available, it is not equitably distributed to people who we actually require.
Very, very serious point raised, and I'll take the last point that you made first. Is if the delay in linking that patient to treatment is 3 months, it's criminal in my opinion, because that patient was I mean, and without any fault of that patient, is transmitting TB to others, and it could have been the sensitive, or it could have been a DRTB which the patient is transmitting. So that is a serious situation, and I absolutely agree with the quality assured result that you are providing is going out from your lab. That is very important again, and that is why we also say that a negative predictive value of any test, which you are saying that if you are saying that confirmed negative, then it is a confirmed negative, or the sensitivity of test, that also is very important. Although missing millions now have gone down, like it is lesser than the patients that we were missing earlier. We have come a long way on that. Program has also done a fabulous job on this, but yes, we still have some work to do before we can say that we are eliminating TB. So with this question now, I'll bring in Dr. Reena, and so asking you, ma'am, yes, there are multiple diagnostic technologies are available, and but like what Dr. Mary was saying, that still, or Dr. Savaj also mentioned, that TB diagnosis still occurs at an advanced stage, or the treatment gets started at this gap. From the system's perspective, some of the things Dr. Mary already actually mentioned, but we'll look at reiterating those points plus your insights on what all are the key gaps in diagnostic pathways, in referral mechanism, which Dr. Pratik also mentioned, and in the clinicians' awareness itself that contribute to these delays.
Thank you, Dr. Swati, for the question and having me in the panel and letting me share my viewpoints. See, basically, I want to reinforce the points actually brought in by Dr. Pratik as well as Dr. Mary. So, what is the most important aspect of this is high index of suspicion, which I am sure that all other panelists will also agree. So, when we talk about high index of suspicion, I am not confining that to only the medical fraternity. As Dr. Pratik pointed out rightly, the patient's awareness is also equally important. So, I know that there are a lot of advertisements happening from the government side, giving advertisements in TV channels, radio channels, as well as in the newspaper, that cough more than 2 weeks, we should suspect tuberculosis and seek medical help. So that is there, but maybe there has to be some extra effort in terms of maybe putting up some banners or screens in hospitals, or whether there is crowded places, or whether there is people are gathering. So that is one way we can increase awareness among patients. Second is increasing awareness among medical fraternity, the practicing doctors. So unfortunately, I am sharing the same observation which Dr. Pratik had shared. By the time patients come to, like I am from a tertiary care setup, so many patients, when we get into the detailed history of these patients, we realize that they were roaming around with fever on and off, cough, and have approached 2-3 physicians, maybe general practitioners, and they were given azithromycin left, right, and center as if they were having some azithromycin deficiency. I'm not against azithromycin, but many times people don't even bother to investigate them further. So that is one thing which I would like to reinforce. So what can we do? That is the second aspect of it. So here I have in our facility there are certain things which we are taking active initiative, is that one is in any seminar, whether it is medicine, infectious diseases, or microbiology, any conferences, there will be a mandatory session on tuberculosis. So tuberculosis, as we all know, it is a very old disease. It is there from right from the time when mankind exists. But we need is like the webinars which you are conducting, CMEs, all these things will hopefully increase the awareness among clinicians, general practitioners, as well as microbiologists, and all people of all level, medical students, residents, everywhere, that varied presentations of tuberculosis. So right from our MBBS days, one thing which we were always been learning was that TB can affect all parts of your body except your nail and hair. So that kind of varied presentations of tuberculosis all of us are seeing, and which many a times are missed by in many hospital setups. So here in our hospital, what we are doing is we present all atypical presentations, rare case scenarios where clinician suspicions was low on card, but finally it turned out to be a tuberculosis. So such cases we present so that more the students will be more and more aware of such presentations. And also in our laboratory as microbiologists also, we are taking certain initiatives, like the surgeons in case of extrapulmonary tuberculosis, many a times what happened, which used to happen earlier, was that they sent the biopsy sample or anything which is intraoperative sample, they sent to pathology. And when the pathology people report granuloma, that is when they approach the microbiologist, can we confirm the diagnosis? So this, with our active intervention, we have inculcated a culture of sending the sample right in the very beginning itself to microbiology as well. And to a major extent, I feel that we have become successful. And a third point which I would like to touch upon is that in case we find a drug-resistant tuberculosis, then we go back to the clinician and tell them the possibilities of other investigations. Like you may go for a second-line expert, or you may go for a second-line LPA, or if you haven't ordered a culture, you can order a culture. Because these samples, especially samples which are collected intraoperatively, you cannot get those samples after some time when the patient is not responding to treatment. So we go back to the clinician and persuade them to do the test right from the beginning, especially if there is a rifampicin resistant TB by CBNAT. So these are certain measures which we are actively practicing in our hospital.
Thank you so much, ma'am. And again, I think it's my habit to take the last point first. So the DRTB, in case of you are having a resistant TB, and then you are going for a second line and advising the clinicians to have a second line investigation, that's actually very, very important. And by second line, I guess that you are looking at FLQs and second line, injectables
Exactly.
and right. Also, just to add, INH, which probably is, I mean, otherwise is considered in first line, that looking at that resistance also becomes important. And I do have one more question. Actually, will be coming to you with that. But yes, awareness generation in patients, more so I think awareness generation in clinicians. You were very, very right in saying that again, cough, cold, or fever, cough, fever, all these things might be taken as respiratory tract infection, and therefore they'll be treated wrongly and the patient will get worsened. This is important. So kudos to you that you are including TP sessions in all the hospital activities. We will be very, very happy to actually collaborate with you on those things, and we are very happy to take all those TB awareness sessions. It's one of our forte anyways. So with that, then I will go to Dr. Mallika, and exactly what Dr. Reena was mentioning, Dr. Mallika, that once the TB is positive, the clinician then needs to say okay for the, let's say, a second line testing, whether it is on LP or it is on MTB XDR test, expert MTB XDR test. Um, how do you actually align all this? So basically, how actually a better coordination or collaboration between clinicians, microbiologists, diagnostic laboratory can help streamline the overall TB diagnostic pathway, not only just the TB but going all the way to DRTB.
Sure, sure. Yeah, thanks, Dr. Swati, for the question. So basically, I would just like to again add another dimension to your question, that it's not only collaboration between clinician, microbiologist, and laboratory. The first point should be patient only. As everyone was talking, if I would like to sum up all the discussions through a patient's journey or a case. So what happens that whenever a patient starts having like symptoms of cough and cold for 10 days, 12 days, initially though we all, be it in an urban setting or a semi-urban, even rural setting, that we used to ignore that, okay, there might be some weather change or there might be some allergic, that we did not go to the doctor. Now, the second question comes is accessibility to the clinician, that for a rural perspective, there is no much qualified doctors available. So the patient will go to whom? Patient is a daily wage laborer, a farmer. He has to compromise on his daily earning to go to a doctor, to leave that job also. That is one point. And in urban, semi-urbans also, people start doing Googling, okay, we will go to a pharmacy shop and we will have one course of at least anti-allergics and antibiotics very easily, like azithromycin, be it a fluoroquinolone or amoxicillin, are being sold like left and right over the counter. So this already has taken 3 weeks time for the patient. After that, patient feels, no, I have taken the medicine, still I am not improving, so let me now go to a doctor. So now the doctor for rural setting is also, maybe RMPs are practicing when they are getting, so they are referring the patient to the designated microscopy centers. Now, in designated microscopy centers, not always microbiologists are there. A sample has come and the patient has not, like, they didn't get the proper clinical history of the patient also, whether he had earlier history of tuberculosis or not. So then misclassification does happen. And what is the quality of the sputum sample that is being submitted? Very important. Many a time, proper deeply expectorated sputum is not being received by the laboratory. Salivamic sample is coming. So the microbiologist or the technologist need to go back to the clinician or to the patient that this is not an adequate sample. So at least we need a fresh sample. Yes, we are aware that for NTP, it's like a spot, and a next morning, early morning sample will be coming. So in these cases, be it paucibacillary, be it early tuberculosis, or be it a inadequate quality sputum sample, this is all about pulmonary. And in extrapulmonary, it is even more dangerous because we are not aware that what to collect, when to collect, and how to collect, where to collect. So in such certain instances, that when we are giving a negative microscopy report by the microscopy centers or even the peripheral labs, when we are giving a negative microscopy report, the clinician then again assumes, okay, it's a negative, let us start again another course of antibiotics. So another 1 week, 10 days passed. After that, almost after 6 weeks, when patient starts developing, okay, now I am losing my weight, I am having off and on fever, I am being anorexic, very weak, not able to do my job properly. So at that time, patients are being referred to now the district centers. So district centers, we are getting an approach that, okay, we will be doing for upfront molecular testing. Now, upfront molecular testing also, what is the challenge? That rifampicin sensitive cases will be found, rifampicin resistance cases will be found. Rifampicin resistance cases, we usually try to go back to the clinician that, okay, we will be adding reflex testing for the resistance testing for fluoroquinolones, SLIDs or INH, be it by XDRTB, or we will be sending the sample for first line probe assay and second line probe assay. But what about those rifampicin sensitive cases, in which also we are aware that 8 to 9% cases there can be INH resistance, and not even isoniazid resistance nowadays. Even if newly tested TB patients also, almost 20 to 25% of cases are having only monodrug resistance to any of the drugs, be it fluoroquinolone or a SLID. So there points the coordination between the lab back to the clinician, that what is the history, from which part of the district the patient is coming, how many DRTB further cases are there around, that patient may have acquired a DRTB infection rather than a DSTB. So that understanding, so that the reflex testing can be added both in terms of either XDRTB by GeneXpert, or if it is a first line and second line probe assay from the first sample only. And also to motivate, to generate that awareness that, okay, it's better that if we can send the sample to a CNDST lab also, be it a government or a private laboratory, where if we are able to grow the sample, grow the bacilli from the sample, then we have full lot of advantage that we can do anything and everything from that. Because many a times what happens when we are getting a paucibacillary like very low in GeneXpert or trace in GeneXpert with indeterminate rifampicin reports, what happens that even in line probe assay also, because of the very low bacillary load, we are not able to give proper resistance pattern by the hybridization method. So in those cases, culture is very important. So again, there should be collaboration between the microbiologist and the clinician, that these are the reflex testings we will be referring for the patient. And if patient is not able to pay, then go to government setup. If able to afford, then at least transfer them to a private setup. And the third part will be definitely diagnostic laboratories' prime responsibility nowadays, that they should be integrating their LIS with the NICSHAR portal, because real-time information should reach back to the clinician that yes, this patient has been diagnosed by tuberculosis, be it by microscopy, culture or molecular method, so that clinician, be it a private clinician or a government one, they can find the patient and they can start the treatment. So I would just like to give you one of my experience, that what I have seen from patients also, many a times patients do not agree to give or give exact phone number or the address details to the private diagnostic laboratory also. We have tried to motivate them. The government will come to you. You will be given nutritional support. You will be given free of cost treatment, because of the social stigma. So how the clinician also from the very first point of contact, motivating the patient that these are the benefits that you will get, and how as a community we can overall alleviate the social stigma, so that patients are also not fearing to come to the patient. So this is how the whole patient's journey can be smoothened, and delays from every gap, like right from suspicion to confirmation to the treatment initiation, can be reduced by proper collaboration between all these four prongs of the diagnostics.
Yeah, thank you so much, Dr. Mallika. And in fact, yes, this collaboration wherein you are literally guiding the patient or patient journey and the clinician also as to what is next test that you need to do. Patient is in front of the clinician maybe, or they know the patient history more, but you have that sample and you are getting those insights from there. Very important call out on reflexing the sample on either LPA or on XDR to get the complete drug profile, of the first line and second line, so that the treatment of first line, second line drugs can be started. Culture, a very important point again. Culture remains the gold standard. So any TB case positive, probably the culture should anyway be done for them, and any which way, if TB is coming out to be negative and they have pulmonary symptoms, etc., then in that case you will have to send it for culture for non NTMs, etc. The stigma, yes, almost everyone has spoken about, I think, and that has stemmed from long time back, and the Raj Kapoor movies where the hero is coughing blood and then dying, etc. But yeah, we even despite decades passing, this is not going away. We need to probably do a better job on that. Coming back to Dr. Pratik, one important facet that we have seen in diagnosis is the multiple technologies available, multiple platforms available for diagnosis. So sometimes it happens that a test is done on one type of technology or one type of platform, and is reported as other, like, sometimes reported as CBNAT or something. This is, in candid words, is a fraudulent practice, but it's there. What is your opinion about it? And I might actually have a bounce back question also for you.
So I'll just share with one experience that I saw one patient having lymph node tuberculosis, and biopsy was done, and which showed that gene expert MTB detected. So that was the report. Then I flipped the page. I couldn't find about rifampicin resistance. So I called the lab and I spoke with the in charge that what kind of this report is. And then they told me, sir, it's a gene expert report. Then I said, no, it's not gene expert report because you have not mentioned about rifampicin resistance. You only written that MTB is detected and that's it. So I want to know about rifampicin resistance. And then they said, no, it's our traditional PCR report. You are right, it's not a gene expert report. So it's happening nowadays. So I always call back to lab because there are various labs available in my city. So I don't know which platform they are using. So each and every time I have to confirm that is it performed on CBNet or is it through a different method. Because thing is, we need to remember that WHO has endorsed CBNet and LPA for the diagnosis of tuberculosis. If lab is using the non-endorsed or our conventional in-house PCR, then we might miss the diagnosis. So there is a chance of false negative. So we might miss the diagnosis, and there might be chance of false positive due to contamination. So patient might get the wrong treatment. But I'll change the discussion that see, CBNet is easily available in most of the cities, but the problem is at the level of sample collection. So when I send any patient to a surgeon for debridement or like removing the lymph node, the most common response is putting entire sample into formalin. So now, if the sample is in the formalin, we can't do anything. We can't perform the CBNet because the genetic material is lost. So that is a big problem. So any patient comes to me, even if I want to take any CT guided biopsy or anything, I write clearly on paper. I also speak to the surgeon also that, sir, please divide tissue into two different container, in formalin and in sterile container. So in my OPD, almost I would say 30 to 40% of the patient comes with the report, only histopathology, which is showing granulomatous inflammation. And then the patient was referred for starting AKT. Now we need to remember that granulomatous inflammation has many differential diagnoses like sarcoid, like even cat-scratch disease or autoimmune disease. Chronic fungal infection can also cause granulomatous inflammation. So granulomatous inflammation is not tuberculosis. We need molecular diagnosis. And even in molecular diagnosis, apart from sending expert, I would like to send expert XDR panel also because I want to know about what is the status of INH. And additionally, TB culture should be sent. So I think all the my surgical colleague need to change their perspective. Even if they are not suspecting TB, I would recommend that kindly collect extra sample in sterile container. Tell the lab that if it is needed, then later on you can perform all the molecular test. But the separate collection is, I think, the priority.
So, yeah, with this, actually, I also want to ask you. So, you saw this report, and it could have been a pulmonary, a sputum report also, which could have been MTB positive, and then there's no rifampicin mentioned out there. Do you feel if if a system generated report is given to the asking clinicians, that will help? Because let's say if you have that, then you can look at the melt curve peaks, you can look at the CT values and all that also, and determine a better course of action.
Absolutely. So system generated report will give me authenticity that this report is performed on the CBNet, and I can value that report. Uh, in many cases, we call back the lab that kindly give the second page, kindly give the system generated report because we want to see what are the props, whether it controls is run properly or not. Just want to reconfirm that this is the CBNet report. So yeah, definitely a system generated report would be useful.
Thank you so much. And I think you and Dr. Mallika both mentioned that when the patient is TB positive, not only the second line diagnosis, which is fluoroquinolone and ethanolamide and second line injectable, but INH also is important. So therefore, you know, and INH is important, and therefore, even if the rifampicin sensitive TB is also there, as soon as somebody is MTB positive, they should be reflexed for INH, fluoroquinolone, ethanolamide, and SLID in case required. But now I will come with this same discussion line, ma'am, to Dr. Mary, that INH monoresistance, this is a challenge. Dr. Mallika mentioned it, Dr. Pratik just mentioned it. That and generally the testing is not happening for that for the same reasons, like if resistance is taken as DRTB and the sensitive TB is being treated with a traditional regimen and not being looked for the INH monoresistance. What are the current gaps and priority in managing the DRTB, and what will you suggest that are crucial for strengthening that detection and ensuring this accuracy in terms of detecting INH?
Yeah. Good question, and all my panelists have at some point, highlighted, what are the gaps and what is the way forward to. Very true that, so currently we take, whenever we get rifampicin sensitive, we just take it as sensitive and start treating the patient. But INH is a very important part of the diagnosis now, and monoresistance is quite high. And if we don't treat them appropriately, we are not going to treat them completely. So cure is, it'll be an iffy if we don't do that. So currently, what is available is always reflex testing, right? So rifampicin, MTB detected, rifampicin sensitive or resistant, we go into LPA testing, which is either done at the lab or we send it to a referral center to do. So the gap there is the LPA, because LPA is quite technically demanding and therefore not available in a timely manner. So to have a meaningful starting of a therapy which is required for the patient. And reflex testing on the gene expert, like I was telling in my first point itself, the cost. That is what inhibits us from doing anything with reflexly, even if we are very well intentioned. I want a patient to be started immediately. I know it is rifampicin sensitive, but I want a monoresistance or the first line to come completely. It is difficult because I am inhibited by the cost. That is a big gap that I see in the current system of whatever we are doing. So in our system, what we are trying to do now is that, we do a universal, we used to do a testing, since it's a tertiary lab, we do cultures regularly. And we were not doing the direct sensitivity for all patients which come to be positive, because of the cost and other things. But we found now it is, cost effective by increasing the cost a little bit. We used to charge about 2,000, I think, for the cultures. Now we are trying to move it at 2,300 and do first line sensitivity testing for all the people who come to be culture positive. I think that's a very important step that we have taken, and it will be much lesser for us compared to the your CBNet's 10-color fluorochrome assay. I must say, I'm not stepping down the improvements that we have, but this is what I'm trying to tell. And also to remember, if we do only molecular testing, the third gap that I see in this testing is that many times what we see, we get indeterminate results on your first testing, and therefore we are stopped. We cannot do the reflex testing. I do not know the importance of this one. Then the next gap I see is that what we can see is that only the known mutations are detected right now by using your by using any CBNet method for detection. There are only the known mutations can be detected. You will not know a real-time phenotype of what is the actual resistance. And therefore, I might not be able to detect all the possible resistant strains there, and I might be limited by that also. So since this drug resistance is always evolving, that the bug is always one step ahead. So it is very important that we get to understand that, it is not going to be a stationary thing, and research is continuously required for us to keep in line with the organism that is TB. And, we are not going to have any kind of final solution or answer to this. So what I feel is that you must expand your molecular DST panels. It's not that rifampicin followed by a reflex testing. Whenever I meet your people, I keep telling, it should be rifampicin and INH, because I might not want the others, but at least INH I'll want to know. So in the first testing itself, if there is an INH, it will be very, very useful compared to the current tool that we have. And definitely doing cultures and bringing it down to a level which everybody can be accessed is a very important tool. And always making sure that all these diagnostic results are linked directly to treatment. Everyone was, telling how important it is to link our patient with this thing. So like Dr. Was telling about, asking for a system generated report, that is very, very useful. But there is a limitation in how a clinician may or may not interpret this result. So it is very important for the lab also to make a kind of, assessment before giving that generation. I feel it is very important for the government and for you people, if all the CBNAT machines, whether it is TrueNat or whether it is GeneXpert or whatever it is, directly to be linked to the NICSHE. So the NICSHE has the ID number of the CBNAT machines, so nobody can fool us in telling that you have used a machine with something else. And then, so whenever you enter the NICSHE ID and the result of the patient, also quote your number, or if it is directly linked to that, I feel is a far thing, a step that we can take towards assuring quality assurance in any of these things that we were talking about. Thank you.
Thank you so much, ma'am. Yes, and in your previous previous reply also, you were mentioning about the whole quality perspective and turnaround time. You mentioned earlier as well, because it is important so that we can so that the clinician can take an informed decision and put the patient as early as possible on the treatment. Ma'am, one very quick thing is, like, let's say on the culture, when you are doing it, uh, the same method or the same kind of proposition could probably be done for other technology that you were looking at, like addition of some cost and then spreading it out. One point that I wanted to ask, and I'm just digressing a little bit, sometimes we've seen cases where heterogeneous resistance was there, and on culture, the sensitive flora overwhelmed the resistant flora, and therefore, the culture was giving a little bit of unclear report that way. But the point, very well taken. Yes, I mean, the ideal situation would have been all the parameters together, etc. However, the number of probe and everything remains a little bit of limitation in technology. Perhaps that is also an issue. But thank you so much for putting that out. I am the similar line of thinking I am taking to Dr. Reena. And Dr. Reena, like how we were talking about INH, fluoroquinolone is very, very important, turning out to be very, very important. In DRTB cases, when we have to decide whether it is BPAL or BPAL-M to be given to the patient, moxifloxacin becomes important, to be the resistant to be ruled out. Not only that, recently this development in DSTB guideline has come in, where ethambutol has been replaced with moxifloxacin and the 4-month regimen, wherein WHO has approved it, and I think our program is evaluating that. It has not yet come out with that, but so therefore FLQ becomes important in both DSTB and DRTB. I would like to actually ask for your insights on that.
Okay, thank you, Dr. Swati, for that question. Today, I mean, especially in case of drug-resistant tuberculosis, whether it is isolated, I mean, we rarely see isolated rifampicin resistance, but whether mostly in MDR tuberculosis cases, fluoroquinolones become the backbone of the therapy. So, and in my observation, in the phenotypic DST, I have observed that even in fresh cases, we are, I cannot confidently say that whether they are primary tuberculosis cases, because sometimes the history may not be incomplete, but in our experience, we have seen that 20% of fluoroquinolone resistance. Ours is a tertiary care setup, so that may not be reflecting the exact scenario in the community. But in our setup, I am telling that approximately 20% fluoroquinolone resistance is there. So in this particular background, I would advocate that fluoroquinolone sensitivity testing is mandatory, especially in rifampicin resistant cases, where fluoroquinolone becomes the backbone of therapy. And we have, as already been mentioned, that we have 2-3 platforms where we can do, like expert XDR platform is there, or if it is pulmonary sample, we can perform the second line LPA for the fluoroquinolone resistance. And both the platforms are giving promising results with about 93 to 94% sensitivity. So as per WHO recommendation, these are rule-in test for fluoroquinolone sensitivity test, fluoroquinolone resistance basically, and specificity is as high as 99 to 100%. So wherever facility is available, because the availability of both these tests are less, what I have observed, they are available only in tertiary care setups, and that also I don't think in every tertiary care setup. So, and cost is also a limiting factor. So otherwise, I will strongly recommend that fluoroquinolone sensitivity testing has to be done. So what we do is, if patients cannot afford the molecular thing, at least we will recommend that they should go for a which is a delayed report, but they should go for a phenotypic MICHIT-based sensitivity testing, which subsequently may be able to help them to alter the treatment.
Ma'am, so in this case, like just asking on further on this. So let's say a patient has been given first a report of a TB positivity, and then the whole drug resistance profile is not available to the clinician. Do you think it might result in sometimes in incorrect treatment, or if the longer treatment has been given, like the patient might not complete the treatment, and therefore that cost actually nullifies
Yes,
the cost of
I
the
completely agree with you. The
yeah.
ideal scenario would be right from the beginning of the therapy, as much as possible, drug sensitivity profile should be available to the treating clinician, so that he can choose the appropriate regimen for the treatment. So that is why I strongly recommend the same day. Maybe we call it reflex testing of a second line expert, or pulmonary samples, maybe LPA can be done, and the patient can be put on the right therapy. And if now the WHO is recommending that straight away go for NGS for sputum specimens, then we can even get the sensitivity of the or the third line drugs, or we can call that the what you call the repurposed drugs, or the advanced TB drugs like bedaquiline, pretomine, dilinazolid, etc. And at least in cities, maybe tertiary care centers, or at least in the cities where private laboratories are also doing NGS from the sample directly, and are able to provide the entire sensitivity profile of 10 to 12 or 14 drugs to the clinicians, and they can start the treatment, which is an ideal scenario. But sometimes, we maybe because of cost constraints or availability issues, sometimes we may not be able to follow this ideal scenario. That is when I am recommending that at least you should go for a phenotypic sensitivity, so that after 2 to 3 weeks probably the patient would be able to modify the therapy as per the drug sensitivity profile.
Sure. No, absolutely true. And in case if you have it available, leverage these technologies if you have
Definitely.
available, and the concern. And Dr. Mary, if I can bring you in for a minute on the DSTB new regimen, please. That the drug sensitive TB wherein moxifloxacin has been added instead of ethambutol. Um, can you also provide your insights on that, ma'am?
Yeah, that is true. So therefore, our first midget-based testing there may not be really, because we are doing ethambutol only, in the first one in the DST testing. The only thing is that currently still, I think the recommendation has not come from the government of India for us to move to this regimen. However, saying that it is important that we do this testing before we do, like Dr. Reena said, we see a high amount of intrinsic resistance. I mean, people who have not even been exposed to the drug being resistant to this, and therefore it is very important to know the resistance pattern before we start testing. Maybe before we start treating the people with the new short regimen, which is there either for drug resistant or for drug sensitive TB, where fluoxetine is being introduced. Yes, it is very important to do the testing before we start treatment. But like ma'am said, it is better late than never. So if it is not available because of cost, we can always do a course correction once the organism is available on culture to later modify the therapy. But definitely recommended. Yes.
Yeah, so I think this is where, and this actually might be a turning point wherein the moxifloxacin has been added to both DRTB regimen and to DSTB regimen. Coming to Dr. Mallika, ma'am, you are from one of the biggest diagnostic chains, of India. Uh, what is your opinion on strengthening the lab network and expanding access? So we've actually heard access both in terms of financial access and the physical access to the test is not available, sort of thing. What is your opinion, in expanding that access to further tier 2 towns or to rural semi-urban area, and how will it improve the diagnostic capacity and quality assurance?
Yeah, thanks, Dr. Swati. So truly, if we see that over last 4 or 5 years, the government has strengthened the diagnostic system a lot. Like CBNAT, if we see, probably there are more than 9,000 installations of CBNAT instruments all over the India. Even culture DST labs have also increased for more than 100. But what is happening that the gap is not in the numbers, but gap is in the distribution. So if I want to compare this with the general healthcare facility framework of India, that just in the bottom level of the pyramid, if we see there are sub-centers, there are primary health centers, which are like lakhs in number. That is the primary first tier. And above that, there are second tier, that is district level community health centers. And above to that, there are tertiary level centers. What is happening that these molecular centers are mostly concentrated in the third tier and the second tier. But the first tier, which is actually dealing with the maximum number of patients, if we see 1.4 billion is the Indian population, denominator is always high. So even 9,000 CBNAT machines, if catering to 1.4 billion people, every machine needs to cater to more than 1.5 lakh to 2 lakh patients. And that also they have been concentrated in certain sections. So this distribution, if we want to, and it's not only about government setups, even if we see private setups, like we have many laboratories in the district or rural setups, but mostly the TB diagnostics, we have also tried to concentrate in our national and regional level. So we are also not decentralizing it to all the peripheral laboratories that we have. We are doing biochemistry, hematology, but not microbiology. So decentralization will definitely be required for strengthening the system. And along with decentralization, until and unless we are able to do so, because there are many operational challenges also, the next thing that we can do is strengthening of the logistics network, that whenever a sample is being collected, it should be quickly and properly transported, maintaining the cold chain to the secondary tertiary care level centers, so that at least while transportation, the bacteria doesn't lose the viability. Because it's not only that, okay, for molecular testing, viability is not important. But if you want to do anything else from that, if you want to go for culture, if you want to confirm that, because a trace sample has come, an indeterminate sample has come, what are the other possibilities that we can explore? So that logistics part needs to be strengthened definitely. But another thing that I would like to say, because of the strengthening thing is coming, that quality control part. What is happening that if we see going back 3 years, 4 years back also, even IAMM also brought the ICAS just few years back in the molecular part, the CBNAT part. So we were doing only interlab comparison. Yes, NTP has a ICAS system, and as per them that they will be sending 5 DTS samples in a year. So throughout the year, the external quality assurance is very dicey, like once a year we will get, and those reports to be reaching to the tertiary center or the national reference laboratory to have the proper interpretation. Now coming to the internal quality control, what happens that yes, for CBNAT or other molecular things, we are telling, okay, it's the sample probe check, sample process control and the probe check control. If they are okay, we are considering that, okay, reports are coming okay, and there are quality indicators that how many errors are coming, what is the percentage of different sensitive and resistant strains. But like we are using in biochemistry, we are using in other, even the FDA approved or other PCR systems, that there should be a standard reference material that should be used as a quality control strain, which probably tertiary care centers are using that ATCC strain. But when we are going to the rural level, there is no BSL-3 facility. How they will be using those strains as quality control strains? So for quality control, only the SPC and PCC is there, along with few of the quality indicators. So like I would suggest that if it is not bottom to down PT, but if even people can be told that from the primary centers also, people can be sent samples for interlab comparison to the IRLs, to the NRLs at least twice a year, so that they can they can have the report, and finally the quality assurance can be ascertained. So first was decentralization, logistics improvement, quality control improvement is very important. And lastly, efficiency of labs, like the labs which are having CBNAT, how much they are utilizing, the optimization of operations, how many hours they can actually perform, how many tests they are doing. They're doing maybe 8 to 10 cases, that's the average. But if a lab is running for 8 hours and every sample is, we are getting a report in 1.5 hours to 2 hours maximum. So 4 modules, 16 tests can be done very well in an 8-hour shift also. So this is how we can strengthen the efficiency of those labs who are actually having the test. So these 4 points will be very crucial for strengthening the gaps in the testing.
So very well put out points. And decentralization, of course, I mean, it will rather take care of the logistics, because the sample is being tested right then and there, and the access is improved. But in case that is not possible, logistics, yes, of course, I mean, the maintaining the cold chain is important. Quality assurance is a very, very good point, and I will actually change the sequence of my question and go to Dr. Reena with that. An efficient process with gene expert is something. Yes, you can actually have like a very well counted kind of testing done on those modules. So that needs to be leveraged as much as possible, any which way. It's a good technology. If it is available, it needs to be leveraged. Dr. Reena, I will actually break the sequence, and I'll come to you, because we spoke about the external quality indicators. You are working in this leading tertiary care hospital. One is how the speed and with precision, how are you maintaining that in the lab? But more importantly, what I will like to hear your perspective is on the role and importance of EQUAS in strengthening quality standard. And everyone spoke about quality standard. Dr. Mary was talking about quality, so that when the result is going from the lab, it's a confirmed result, whether positive, whether negative. Dr. Mallika specifically is mentioning how can you actually strengthen with the quality standards of the labs. Dr. Pratik spoke about it. So if I can have your input on the perspective and the importance of EQUAS, ma'am.
Okay. See, EQUAS is very important, but at the same time, before going to EQUAS, I would like to stress on internal quality. That is something which we should maintain first, and then EQUAS. So in internal quality, there are certain many parameters which two of the other speakers had also mentioned earlier. So right from the rate of contamination in midget, whether the contamination in whether your decontamination procedure is optimum, whether your contamination is more than 5 or less than 3, all these things are to be put in place. And if you are going to molecular assays or smear, especially in molecular assays, your kit QC and if you are using two platforms, the comparison of reports between the two platforms, like if you're using GeneXpert and TrueNat, you can, or if you're having 3-4 GeneXpert machines, you have to find the agreement of the reports between these machines. And then between technician competency record, all these things are to be in place. And then comes is the role of external quality assessment. So we are a center who is providing external quality samples to north as well as northeast part of the country, where we are giving smears for FB smear as well as molecular testing for tuberculosis as well. But the thing is, there is, as of now, there is no single center which is providing samples for culture as an EQUAS program, because there are a lot of challenges associated with preparing an EQUAS sample for tuberculosis and sending to a lot of stringent guidelines are there in preparing and sending those samples. So, but still we are working on it. Probably in the near future we will come up with a solution for that as well. And but as of now, I think what we can do is inter-laboratory comparison, which we are also doing, and many other centers also would be doing with the 2 other NABL accredited laboratories we can do. And for molecular testing and smear, you can definitely enroll with Sir Gangaram Hospital EQUAS Center, which is providing this facility. But yes, as Dr. Mallika was mentioning, this is the samples are being sent only twice a year, and by the time the report is they get the report, analyze report, it may be after 1 or 2 months only. So these are the challenges, but that is why I am stressing on the internal quality is also very, very important.
So I'm hoping Dr. Mallika actually, collaborates with you on this whole quality standard, and I'm hoping if there is some like SOPs that can come out for labs, for these improvement in the quality standards. Yes, internal is important, internal quality, and then going ahead and having the external quality standardization as well. Important point that you noted is that if you have a number of platforms, or if you have number of machines of, let's say, GeneXpert itself, all the machines need to have the reports agreement done on that. So those important points. Now now let me come to Dr. Mary, and then we will go to Dr. Pratik. Is that, now I'm coming to very, very basic question, ma'am. Smear microscopy, while has been mainstay for quite long. However, now upfront molecular diagnosis is being advocated. How can we accelerate this shift? Also, smear microscopy has its own limitation. While there are some benefits, but it has its own limitations. So, how can we accelerate the upgrade of the technology from smear to upfront molecular diagnosis?
Yeah, thank you, Dr. Swati. Yes, very pertinent question. We are very reluctant to let go of microscopy. Even in a tertiary care center like mine, I would still want microscopy done. That we will discuss a little later. But definitely, if you're looking at elimination of tuberculosis, molecular is the way ahead. Because, the first point we talked about is about resistance itself, right? So we need to know whether somebody is drug resistant or sensitive. That is very, very as much important as knowing somebody's got TB or not itself. So, that universal drug testing, whether it is just rifampicin or reflex testing or whatever is available on a molecular platform, because of its ease of doing and a turnaround time, which is very meaningful, is definitely a push towards recommending CBNAT for all the people who are suspected of tuberculosis. The challenges that we see in really pushing them and not really not doing away with microscopy. Microscopy should serve as adjunct only, like simultaneously you must be doing molecular, start with molecular and then simultaneously do a microscopy. Why microscopy? Is that many times, like CBNAT says, indeterminate. So what do I do? So what should I treat the patient? Should I not treat the patient? Many times, we get on a ball or, on samples, especially extrapulmonary. I know that microscopy is has very low sensitivity on the extrapulmonary samples, but in a very experienced microscopist, it's still very good. That is in one situation where microscopy may be useful. Second thing is, again, when you're looking at a tertiary care center like St. John's and other people who are esteemed panelists here who are also at one, is non-tuberculous mycobacteria, which will not be picked up by the CBNAT, but microscopy will be very, very useful there. So we cannot do away. Again, will serve as an adjunct to the CBNAT. The third situation will be when the patient is on treatment. Now, when I cannot use a CBNAT to say whether somebody is going into, whether it is persistent or not, or whether he is going to drug resistance. I may not be able to use it at all to say whether somebody is going into resistance just by using a CBNAT. We know it is not endorsed for a follow-up. So we cannot do away with microscopy, but like you said, upfront, if you're looking at elimination, CBNAT is the way ahead because it gives us outright sensitivity. Even if it is limited, it does give you a great, strength towards opting the kind of therapy that somebody requires for, to go ahead with the treatment. And always course correction to think, suppose it is not, or, INH monoresistance is there, or some other resistance is there, which may be picked up later by a culture and those kind of things. So upfront, but you cannot do away. And with one more thing with microscopy is that now with a lot of AI tools coming in for microscopy, so, you may not even require a trained microscopist. Maybe you can train your AI to pick up these bugs, even as Dr. Pratik was telling that time, people who send off the tissue samples to pathologists without thinking of microbiological or molecular diagnostics. So if there is an aid of an AI tool which can easily and correctly identify even the last TB bacilli, which may not be picked by the human eye, if an AI can be trained to pick up and trained there, it is definitely useful. So we cannot do something away completely. It's always best to have that as an, we should not lose our, microscopic capabilities, because we have come a long way in that. So I think it is also important, but definitely for elimination, CBNAT is the way ahead. Yes.
So
or molecular diagnosis is the way ahead. Yeah.
It's not or situation, it is end situation wherein you use all the technology to its best advantage. And yes, very well pointed out on the NTM portion, which finally has to go for culture for patient management any which way. And also, yes, an important point, and I will reiterate on that. CBNAT is not for patient monitoring. Patient history becomes very, very important in terms of, because molecular diagnostics will pick up dead bacilli as well. And if the patient was on older treated TB patient, it will pick up. So monitoring cannot happen on this. Monitoring will happen either on smear or will happen on culture more likely. So that is where, and culture remains the gold standard of diagnosis. But well pointed out by Dr. Mary is that upfront molecular diagnostic helps in quickly and accurately identifying and detecting the TB cases and linking them to the care. Dr. Pratik will come to you, and this is also something we have on audience question as well. Is that early clinical and you had spoken about it, that early clinical suspicion is is a good way to have the TB diagnosis. And we are re-emphasizing that message that you gave earlier. How can we, strengthen basically, or how can clinician across specialities, and I'm not saying only pulmonologists or microbiologists, um, like internal medicine people and gynecs and everyone else also, be better informed to recognize early symptoms and initiate appropriate diagnosis, at least for TB, like general practitioners or people like that. And the other, so with this other question that we have received from audience, and you had answered, but maybe we can say it again, is this: which patient population has so I'll read out the question itself to you. uh, that is there any specific patient profile or symptom where TB is often missed or misdiagnosed? So these are the two questions I have for you. How can we better inform the clinicians to be able to recognize the TB symptoms, and the patient profile which is more likely to be missed for TB?
So as you correctly said, that TB is managed by so many specialty doctor. Like it is not the like pulmonologist or general medicine or critical care ID. It is all the other specialists. They also manage tuberculosis. Even my gynecological colleague, my surgical colleague, they also manage the tuberculosis. So first thing I would emphasize on change of attitude. Like at the primary healthcare giver as a general practitioner level, I would suggest that rather than trial of antibiotic, a trial of radiology or trial of molecular testing would be more helpful to pick up the early tuberculosis. And at a physician level, even I would suggest same thing, that rather than trial of antibiotic, appropriate use of molecular testing should be the the best idea. And for surgical colleague, I would suggest them to collect sample appropriately and sending it for appropriate test. So I think we just need to change the attitude, like giving fluoroquinolones, as my previous speaker also mentioned about the giving azithromycin for cough and cold. And I'm also worried when fluoroquinolones or linezolid, they are given on outpatient prescription, because these are the drug, they have anti-tubercular activity. So that might suppress the symptom, or that might delay the diagnosis. So we just need to change our attitude towards the testing and diagnosis.
Yeah, so I think well said. And because early disease might be possibly, so therefore, having, rather than relying on chest X-ray, probably upfront molecular diagnostic will be better in that way. This I have actually heard a lot of other specialty cases where they are suspecting TB, they'll just send it for X-ray, uh, which really doesn't work. So well said on that. Can I also ask you to, mention the patient profiles which you think,
Ah, yes, yes, yes.
specific
Right.
patient profiles where we might miss tuberculosis?
Yeah. So, see, when patient is having diabetes, so they might have atypical symptom, or patient has a compromised immune system, like advanced HIV patient, or patient, if patient is neutropenic, you might not see the infiltrate in chest X-ray or infiltrate in CT scan, or you might see the atypical presentation of tuberculosis. So these are the patient profile in which we might miss the diagnosis of tuberculosis. Even like extrapulmonary lesion, like hepatosplenic lesions, or spondylodiscitis, spine lesion, even they are often missed if sample collection is not done appropriate, or CT guided biopsy is not done appropriately. So these are the patient profile in which we might miss the diagnosis.
Yeah, and I mean, Dr. Reena also mentioned that specifically, that many a times other specialty clinicians, they miss, and sometimes they are sending for biopsy, and then after looking at the granuloma, that on the histopath slide, that they are asking for TB diagnosis. And a good point again, just to reiterate, is that So in Sir Gangaram, they are doing all these kind of education activity to generate awareness among the clinicians. So just wanted to bring that up. And Dr. Mallika, uh, we've spoken about the disease, we've spoken about the patient management. Is there somewhere government can help? Is there somewhere a PPP like thing, a public-private partnership kind of arrangement, be better for TB control? That is and diagnostic companies, the laboratories and government, if all of us can collaborate better for TB control. Your inputs on that, please.
Yeah, I think already government and the private players are working together hand in hand in India for last quite a few years. Like all the district and level CMOH, everyone comes to the private laboratories also, that how you are doing, how you are notifying in Nikshay portal or not on real-time basis. If any report is being missed to be uploaded, then also we do get reminder from the government people. So the collaboration is already there. It's definitely, but yes, every time it can be strengthened further. If we see that government will always come up with the algorithms, the standardization of the processes, but in private we have to adopt that properly. So not all private diagnostic laboratories also probably following the proper quality control procedures, proper standard operating procedures. So that is where private people needs to work with, as I told, that real-time information, like real-time entry of the data in the Nikshay portal, so that the government and the clinicians do get the information for tracking, contact tracing of those patients, so that they do not continue to spread the disease further, for quick treatment initiation. Another thing, when coming to the new technologies, what happens that yes, TBs are very standardized, but otherwise, if anything new is coming to the market, be it an AI-enabled screening of smears, AI-enabled digital X-ray reporting, so those things, it's sometimes we see that the private people, we do adopt early. So, but once we are adopting that, the government, they can scale up. They can again scale up the process and they can redistribute it overall across India. So that will be that we will be bringing out the technology, but government can help us to scale up that. So that will be another point. And fourth point, I would reiterate that capacity and capability building, that more training programs from the NTP for both government as well as the private clinicians, be it microbiologists, be it technologists. So that sort of coordinated training programs can happen more frequently, so that the public-private partnership is more strengthened. So these 4 points I would like to iterate, that algorithm establishment and following, followed by bringing in new technologies by the private people that can be scaled up by the government, capacity and capability building, and of course, real-time addition of the data to the Nikshay portal. So this is how it can be strengthened.
Very well said. I mean, while the diagnostic labs can adopt better quality standards, the government needs to be a little bit more agile in terms of taking these new, new upcoming technologies and leveraging them much faster. Capacity building is a very, very good point, and I think quite doable. Hopefully, somebody is listening to us on that. And with this, then I'll there was a plethora of information. There was like it was a very wide reaching information. I was able to put in some pointers, which I will take it as a consensus document or consensus statement. But first thing, I guess I wasn't expecting that patient awareness point has come up from all of you, that patient needs to know what are the symptoms. Otherwise, self-treatment diseases versus it being TB is a crucial gap that we have, and that is where the capability building, capacity building, the awareness generation, etc., will help. Upfront NAT for TB elimination, along with leveraging other technologies for better management of the patient, that is important. We all agreed also on the while the RIF resistant TB is being taken as the DRTB, the sensitive TB also needs that kind of outlook wherein INH and fluoroquinolone profiling is important. And the point that I wanted to also mention from my side is that DRTB is not that it spreads first as DSTB and then grows to become DRTB. It spreads as DRTB. So it is very, very important that we have the patient drug profile done very quickly. Also, what happens is, even if the person has come with drug sensitive TB, the wrong treatment or incomplete treatment, incorrect treatment might actually make this disease a resistant disease. So therefore it is very important that we know what is the treatment regimen that needs to be given to the patient. Decentralized testing, Dr. Mallika spoke about it in terms of better access, and all of us, in fact, all the panelists spoke on the patient having access to the technologies, the good quality diagnostic care. That is something which is important. And yes, we also spoke that MTB positive case needs to be reflexed. Either the reflex can happen on LPA or it can happen on CBNet or any other technology. Culture remains the gold standard, but only a little bit of gap in terms of LPA is that it is highly skill required technology, and it might be that turnaround time is higher. So therefore XDR becomes a same day sort of diagnostic option. And the other thing which Dr. Pratik mentioned is that a system generated report kind of thing, or just rechecking on the report will give you the report that you had asked for, because each of the technology differs. It differs on LODs, it differs on its NPVs, it differs on the sensitivity. So it's important that you get the result from the technology that you had asked for. So that is with all this and multiple other insights that we got, and I have tried to summarize them during the session itself. Yes, we can end TB, and with that, I'm so happy that we had this session. My heartfelt thanks to all the panelists for your insights. We learned from your experiences, and I hope with these insights, people who are listening to you are better equipped now to handle the TB cases, and we can probably fight this menace which has been there for a millennia. So with this, thank you so much to all our panelists. Vaishnavi, if you wanted to please take over. Thanking you to the VOH team as well, if you want to please take it over. Otherwise, we will say bye from our side to all the panelists. Yes. I guess we can have a good day now on. Dr. Pratik, Dr. Mary, Dr. Reena, Dr. Mallika. It was amazing to talk to you.
Thank you very much for having me.
Thank you.
Thank you very much.